Welcome everyone to our Implementation Science Seminar series sponsored by the New York State Psychiatric Institute and our CTSA. Just a reminder that this is being recorded, so if you don't want to have your video on, please turn that off now. This month, we are so thrilled to have Dr. Maji Hailemariam, who's an assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Biology in the College of Human Medicine at Michigan State University. I've been a huge fan of her work in implementation science for a long time. She's done some really excellent work looking at health equity, and sustainability. And her work is really focused in a lot of global settings on equitable access to mental health care, underserved communities, including women and justice involved populations. And she's going to talk to us today about her work on planning for implementation of integrated primary mental health care in a low resource setting, evidence from Ethiopia. So please welcome Dr. Hailemariam.
Thank you for such a generous introduction. I appreciate you allowing me to speak with this group and sharing my work from Ethiopia. I work between two completely different continents, but in issues that are highly related, which is low-income contexts, both in Africa and here in the United States. I'm based in Flint, Michigan, and my work in Ethiopia centers around the needs of low-income people with mental health needs in the rural sides of the country. Uh, to give you, to give you a context, Ethiopia is one of the countries in Africa, around the Horn of Africa. It's a low-income country per the World Bank's description of countries. Mental health is not integrated into all levels of the healthcare system. Currently, there are a few efforts to do that, but overall, nationally, we don't have access to mental health care for everyone. So to highlight a little more on the country, it's a population of over 115 million, the second most populous country in Africa. The healthcare system is decentralized along hospitals, primary care facilities, but that decentralization did not really translate to mental health care access for many people because mental health service is still highly centralized. We have a very few psychiatric beds and psychiatrists nationally, and all of those are located in the capital or big cities. For a population of over 115 million, we only have a couple hundred psych beds nationally. So when the need is this pervasive, the regular specialist-based approach to mental health care is not going to work. That makes integration very vital for mental health care. We already have existing physical healthcare infrastructure, so the integration would mean adding mental health component to the already existing physical care infrastructure in the country. The other thing that also would make implementation or integration of mental health care difficult is the fact that we don't have a national health insurance. That also means families have to pay out of pocket for their health care. That is a challenge, especially when people have healthcare needs that require long-term and ongoing access to care. In this context, underserved populations are mostly women, rural residents, people who are low income and who live in geographically remote areas of the country. The National Healthcare Plan has defined that every family will have access to a primary healthcare provider within an hour distance, but that distance is mainly straight line Euclidean distance that does not take into account the reality of topography or access to transportation or physical functioning impairment that people have to work long distance to get to the facility. So we may have people who are working maybe 4 or 5 hours to get to the nearest healthcare facility. But what really makes me hopeful is there are efforts underway to develop evidence for integration of mental health care into the existing healthcare infrastructure in the country. One of those efforts is the Program for Improving Mental Health Care project. It is a cross-country initiative involving five low-income contexts of Ethiopia, India, Nepal, South Africa, and Uganda. The target is per the World Health Organization's MHGAP initiative. There are priority disorders. So with the program, the PRIME project selected four priority disorders, which is psychosis, depression, epilepsy, and alcohol use disorders. The goal is to create a model for integration of mental health care for these selected priority disorders in the lowest possible healthcare infrastructure in the country. Um, as part of Prime, I was a part of the Ethiopia team of this project. So today I'm going to talk about in detail the activities we did while we were planning for implementation of the Prime project. So we picked a district about 63 miles outside of Addis Ababa, which is the national capital. It is a zone with 14, well, it is one of the 14 zones in the southern region, and it has a really good mix of rural urban dynamics, but a lot of the people who needed the service or the healthcare facilities we worked with are mostly rural. Um, we, if I have to show you the typical neighborhood, it looks like this. So you can see how topography plays or how the settlement patterns play in terms of access to care for these people. And it's a small community with agrarian livelihood, no big economy or no known transportation access. So we have to consider all of that into account while planning for implementation of integration. Planning for integration of mental health care into primary care settings. There are various challenges in this community because we are basically starting off from a setting that has no mental health access. So that also means the existing healthcare system has no mental health indicators, and the system is not set up to offer mental health care. And we're trying to create systems and indicators for the integration of mental health care. Um, there was no reliable information on some of the health service data we needed. There was no organizational requirement again from the health facilities side to offer mental health care. And it wasn't part of the health reporting, monitoring, and evaluation system. Um, the other and probably the most important component is there are no models of interagency collaborations for traditional and faith healers to work with the healthcare system. I'm raising this here because in this community, when people have mental health challenges, the pathway to care mostly starts with the traditional healer. So they go to the traditional healer, and then once they exhaust all the religious and faith avenues, they come to the modern provider. But the biomedical providers don't have a model to work with the existing traditional healers from the community. So these were some of the challenges when we identified when we were evaluating the implementation context. But I want to say we also had facilitators. Those include the health system level. For example, we had very strong models for tracing and detecting cases of HIV or tuberculosis in the community. they also had a really strongly set up mechanisms for ensuring continuity of care and treatment engagement for people with long-term conditions. We thought this model can also be extrapolated to include or to benefit people with mental health care needs. Um, we also had outreach and adherence support for other health conditions or non-communicable illnesses in the community, which we thought would serve as a framework for integrating mental health into the existing system. And we had another huge, extensive network of community-based healthcare workers and community health volunteers. This is a group that goes from door to door. They know every person in their community, and this network stretches across the area, across the country, across the region. So it's an easy way to tap into those resources, which when we actually launch the service, we can use this for referral and maybe follow up of potential people who might need the service. Um, so we did a lot of implementation related activities for understanding the context. One of that was reviewing publicly available health services and systems data. We did situational analysis of the health system in the district, and we also did an assets mapping of the area. This was critical because I want to emphasize sometimes when we talk about low income communities, people equate that with low resource, which is actually not true. Because in this community, we identified a lot of traditional healers, churches, religious groups, saving associations, microfinances. All of this, they may not directly offer the service, but we can use those resources when we plan rehabilitation and social integration of people treated by the program. Besides that, we did a theory of change workshop or a series of workshops actually with community within our study team, cross country, and with policymakers nationally. Um, I'm not going to talk about all the details of the implementation related activities we did, but I want to introduce the how we used the theory of change approach for planning the implementation of mental health care in this low income setting. So the theory of change approach, some of you, I'm sure, are familiar with it. It's a workshop-based model where you identify your current circumstances and the final impact of the program you wish to see. Then you keep working on the missing middle. So you create outcomes and conditions that can lead to the final desired outcome of the program. In our case, we wanted people to be treated and we wanted people to have improved um, mental health and social outcomes. So for that to happen, given the current circumstance where there's no treatment, what do we need? So we were trying to work that missing middle when we were using the theory of change workshops. So we had to identify the required interventions at each step when we were filling out the missing middle. Our purpose was we wanted to understand how the complex contextual factors interact in the delivery of mental health care. And we were also trying to see how we can use the existing systems to plan the integration of mental health care in this district. So it is about how and why an initiative works. And it's important to map out the short term, the medium term, and the long term outcomes of an intervention. When we create the theory of change map, basically what it looks like is you have the first part, which is the current circumstances or the challenges part filled. And then you have the final agreed upon outcomes of the program that you wish to see at the end of the intervention. But those two are not connected. So your role is to work through the whole middle to make the final outcome happen. What do you need in the middle? So filling that missing middle was a process we undertook with a number of stakeholders in the district and outside of the district. We used a very iterative process involving multiple stakeholders, and as the involvement increased, it also means we have more stakeholder buy-in. People have shown political commitment because they are with us planning this work, identifying interventions and indicators for each of the intervention at each step. So it looks like the process goes like this. We did the baseline situation analysis before the intervention. Then we have the desired short-term change that's necessary to achieve the final outcome. Then there's the main outcome of the program we wish to see as a long-term outcome in our case, which is the improved health status of the people treated. And we have the eventual impact of the project, which is a very broad impact we wish to see. The red broken line in the middle is the ceiling of accountability. It basically means you have outcomes you wish to be held accountable for that are directly related to the interventions you are doing to make that change happen. But there is also broader and eventual impact of the program that might happen. The ceiling of accountability separates that outcome that you wish to see, but you are not responsible for, or you're not committing to be held accountable for. So we worked with our participants trying to identify what outcomes we're going to be held accountable for and what outcomes can come as a result of the intervention that we wish to see, but we were not committing ourselves to. Um, the process looks like this. We had the cross-country theory of change workshops, which were done with teams from Ethiopia, Uganda, South Africa, Nepal, and India. And then we had the Prime Theory of Change workshop, which is our working team's theory of change workshop. And then we went and did one with the community, and we had another one with policymakers. Uh, the final theory of change map that we used for the mental health care planning is a map that combines all the feedback from all the theory of change workshops we did. So we included a very diverse list of stakeholders. The goal is not just to hear what they have to say, but having them involved at early stage of the implementation planning also means securing their political buy-in. For example, when we included traditional and faith leaders, we asked them, would you be willing to be trained and do referral linkage of people with services? And they were committing to that. When we did a workshop with the policymakers, we asked them about budget allocation and creating reporting mechanisms for mental health at the lower level. We had their commitment. So it makes it easier for us to go back to those people when we are actually doing the implementation, because we already have their commitment at this stage. So when we started off all the theory of change workshops, how we started off is we assess the current situation. For example, one of the things that came up from the assessment is at the time there was low mental health coverage district-wide. People, like 90% of people with serious mental illness go untreated. Only 10% of people had lifetime access to treatment. That is mainly because people have to travel out of the district to receive treatment. So that meant a lot of people had no lifetime access to any form of mental health care. And there is a lot of human rights issue because families are responsible for caring for their member with mental illness. And that meant in the absence of care, a lot of people are chained up or shackled and they stay in their houses. And the only accessible and probably endorsed mechanism in this kind of setting with taking someone to traditional healers, not because they are super affordable, but they are accessible and in most cases culturally acceptable. A lot of people tended to go to traditional healers for mental health care. And for the few people who sought care, it meant traveling to other places outside of the district, which has implications. In addition to covering their healthcare expenses, they also had to travel and spend money trying to stay somewhere else outside of their community or their house. Um, so what do we want to see? We had to, this is the situation, but we need outcomes. We need to write down the missing middle. To highlight the missing middle, we had to use the community level, the healthcare facility level, and the policy level outcomes. We were working with our workshop participants on filling out the missing middle as we planned the the integration of mental health care in this setting. So at the community level, we wish to see improved detection. We wish to see increased referral of cases by health extension workers and families. And for that to happen, we need to sensitize and engage community-based organizations. We need to work with community leaders, teachers, health extension workers, health development army. These are all list of resources I mentioned earlier that we can use to plan interventions with or to work closely with to make the outcomes we said should happen at the community level. At the facility level, we have healthcare staff, but they are not trained. So they need to be trained on how to detect and treat the identified mental illnesses. And we have to raise the competence of the community health extension workers. This is a group that has a 1 year training post high school, and we have to train them on at least key symptoms of mental illness so they can um, see and identify people with probable mental illness and refer them when they do the house to house visits. We also had to create referral linkages to community-based support. So sometimes you have people coming and being treated, but they may not have access to the resources in their own community. So creating that referral linkage was important. At the district healthcare or healthcare administration level, this is more like a policy level outcome. There, we want to see availability of resources and trained personnel for mental illness, for treating mental health. We need awareness raising, especially of the district level healthcare administrators working directly with people. We needed demonstrated political commitment. So we have leaders who are coming to our meetings, but we want to know that commitment translate into an action or intervention. And we need non-stigmatizing attitudes at all levels. And we need engagement in advocacy initiatives. Um, so assumptions are like the glue in the theory of change process. What this means is when you have a series of outcomes in the missing middle, you are actually linking one outcome with another outcome by with assumptions. So when you say this will lead to the next outcome, you are making an assumption in the middle, and those assumptions need to be outlined. We had to assume that people would be available and they are ready to seek services. We had to assume that sensitivity towards the needs of people with mental disorders will increase. We have to assume that the facility administrators and healthcare workers are willing to undergo the required trainings. And at the district level, we had to assume that there would be political commitment, willingness to allocate budget, and readiness to provide mental health interventions as they become available. Um, so the indicators, these are the tricky part with theory of change approach is for every little outcome that we insert in the missing middle, we need to outline the indicator for that. So when we say people will be sensitized, what do we mean? What are our indicators? When we say uh, there will be a political commitment. What do we mean by that? So, for every level of outcome, whether that is short term or long term, we have to pinpoint and single out every tiny indicator that we need at each step. For example, when we say improved healthcare, like for people to see that there are improvements in their health, we have to have outcome indicators in terms of um, clinical symptoms like reduction in psychotic symptoms or improvement in mental health related disability. For social and economic outcome indicators, there is a high rate of stigma. So we say that those outcomes improved. We would be able to say that they improved only when we see people with mental health challenges treated by the program are actually able to be reintegrated to their community and are able to have their economic situations improved. This families with a person, a family member with serious mental health issues in rural settings in Ethiopia mostly drift into poverty because, for one, the person may not be providing because of the mental health related disability, or family members spend a lot of time caring for the person with mental health needs. So when you treat the person, those people are going back to working, so their outcomes will improve. So all of these outcomes had to be outlined in the map. This is a very simplified view of the map, the final theory of change map. We have three levels of care, which is the healthcare organization, the policy level, the healthcare facility level, and the community level. So we identified factors relevant to the context at each level, and we identified indicators and assumptions and everything in between for um, the outcome to happen. So, uh, for example, if I have to pick the healthcare facility level outcomes, the context is there is no doctor, no mental health professional, very minimal mental health training, no psychotropic medications in their drug list. That is what the context looks like. For political buy-in, we had like we need another outcome series that includes non-stigmatizing care, detection and referral treatment, medication support, adherence support, and a detection of relapse. And having to do all of that will mean there is a competent, inclusive, and continuing service delivery, and that will ultimately lead to improved health and social and economic outcomes of people treated by the program. Earlier, I talked about broader impact. So, in the impact side, we want to see improved health, social, and economic outcomes of people living with priority disorders in the district. And we want to see a reduction in poverty, reduced risk factors, but these are broad. They may or may not come as a result of our intervention, but these are also broader outcomes we're interested in, but are not responsible to be or are not willing to be held accountable for. At the community level, we have community-based organizations, faith-based organizations, and the health volunteers and the health development army. Um, what I said earlier is the context, I like to frame it better because we have rich social capital. There are so many self-help groups, and there was no specific mental health related charity. The political buy-in that we need at the community level would be raising awareness to utilize the services, reducing mental health stigma, engaging in advocacy, adherence support, and referral linkage with services. And for that would lead to persons with priority mental disorders being referred and mental health being supported in the community. And ultimately, that would result in the long-term outcomes being real. The implications of this work is the theory of change approach. It's a planning approach, and it can be an implementation approach for mental health in a low resource setting. And the theory of change map, can also provide a roadmap or a mental guide for implementation process or monitoring and evaluation of the program outcomes. Engagement of multiple stakeholders also means there's a huge opportunity for gaining political commitment for your intervention and leveraging more social support for uh, the program. These are some of the related papers from this work, and thank you.